Well, hi, everybody. My name is Garrett Schmidt. I am the managing editor and CEO for BBC Exhibit Hall. Welcome to today's live webinar hosted by ATTAC Consulting Group. And today's session is called the 2025 Essential Risk Adjustment Insights, how plans and providers can stay ahead of regulatory changes and compliance challenges. There's going to be a lot of great information covered today. I got a little bit of a sneak peek ahead of time, so I think you'll enjoy the subject matter. A few items of note before we get started. Everyone has joined today in listen-only mode. This is a traditional webinar format, so you don't need to worry about turning off your camera or your microphone. We can't see you or hear you, but we do want to hear from you. We're going to have a time for some Q&A towards the end. So if you have a question for either of our speakers at any time during the presentation, you can drop that in there's a module that you have as an attendee, and there's a place for questions specifically there, so you can put your questions there. We're going to get to as many as we can during the allotted time. If for some reason we're not able to get to yours, don't worry, someone will reach out to answer your question via email. So finally, the session today is being recorded. So what's going to happen is about an hour, I would say an hour after we're done, you will receive an email to where you can see the recording, and you can share that with colleagues and friends, as well as to download the slides. So we hope that you will do that. So without further ado, wanted to briefly introduce our speakers today. With us, we have Mr. John Rogers, and he is a senior consultant with ATTAC Consulting Group, Risk Adjustment. And we also have Mr. Alan Braddon, and he is also a senior consultant with the ATTAC Consulting Group Risk Adjustment team. So welcome, guys.
Thanks, Garrett.
Thanks.
Quick overview about ATTAC Consulting Group. So ATTAC has been supporting managed care organizations for over 20 years across a variety of different domains: risk adjustment, regulatory compliance, provider networks, program development, OpEx or operational excellence, medical and pharmacy management, business transformation, IT systems, and really across Medicare Advantage, Part D, Medicaid, duals, ACOs, ACA, really across the board. So again, I'm John Rogers, that's Alan Bratton, and really wanted to jump into the agenda today. We're going to go over a few important upcoming risk adjustment times, or upcoming dates for the RA programs. We're going to look at some of the activities for the upcoming calendar for 2025, and then we're going to dive into setting strategies for that 2025 risk adjustment operations year, right? So really looking at 6 main programmatic components that are going to be important. And then we'll look at some of the OIG and other regulatory changes that are coming down the pike. So with this, many of you can relate to this graphic, or at least a lot of our clients do, and that is, this is a very busy time of the year. We have 3 different benefit years that are kind of all going on simultaneously when it comes to MA, when we talk about wrapping up 2023 dates of service for the January sweeps, when we talk about finishing up prospective programs for 2024, then ultimately rolling into 2025 when it comes to dates of service 2025 that will be impacting payment year 2026 for like MA as an example. So really it is a crazy time of year. There are a lot of moving pieces, and depending on who you ask, they're all of great importance, right? You couldn't necessarily define one single most important thing that you're doing right now. And so we're aware of that. And so want to really kind of call out a few key dates that are coming up, right? So end of next month on 1/31, we have the final sweeps for payment year 2024 when we talk about 2023 dates of service, right? So ultimately, this is our last opportunity to submit ads or other encounters by 1/31. We can always submit deletes after the fact, but for the most part, think of this as really the final call for 2023 dates of service. Shortly thereafter, on March 7th, we have the mid-year run or mid-year adjustment sweep for payment year 25. Again, that's 2024 dates of service. And so that is it's becoming what I would consider a more prominent deadline, especially as as a nation, as we're kind of moving out of the 0% interest rate environment. There's a lot of push from either the accounting or the finance groups within health plans to ensure that appropriate revenue is realized as early as possible, just because some of the implications when it comes to overall holding on to that cash, as opposed to waiting till the last minute to get data submitted, right? So those are some of the things that we're seeing in terms of best practice across our clientele. And then along that same vein, really, trying to ensure that the initial payment run for payment year 2026 is as complete and accurate as possible as well. And so with that, we have a straddle year of the back half of 2024 and the front half of 2025 in terms of dates of service. So that's on the MA side of the house. Again, there are other important dates, but those are really, big milestones or road markers to look at on that timeline. And then when we shift over focus to ACA, we have RADV is wrapping up here in the next month or so. We have package 1 and package 2 submission deadlines. And then ultimately we have the 4/30 submission deadline for Ed Server benefit year 2024, right? So that's the pencils down. That is the final deadline of getting all of the 2024 dates of service loaded to the Edge server, right? And so then we know after that, typically at the end of June, the high cost risk pool and risk transfer reports are then published. And during that time, we're actually in the blackout period, right, in which data cannot be submitted to the Edge server starting on 5/1. And then usually those are listed somewhere in Q3, August, September timeline. So definitive date, TBD, but that's the general timeline. Again, there are a number of different ACA, smaller sorts of milestones that occur between now and then. But when we really want to highlight the main important ones as in terms of, focus for the first half of the year. Now, with that as the backdrop, it's never a good time to really talk May 2025 strategy. But right now is a better time than ever to talk about what's gone well in 2024, and then how do we transition that into 2025. So when looking at what we consider some of like the 6 main pillars of risk adjustment that I'll share on the next slide, looking at through the lens of these 4 different measurements is important, right? So the first and foremost is, are we achieving our objectives? Are we setting objectives? Are we setting the right objectives? What are we trying to achieve based upon the program that we're running, right? Whether that's retrospective chart review, whether that's prospective interventions, whether that's a member engagement strategy, whether or not we're trying to engage our providers, what are we trying to achieve? And then are we measuring it appropriately, right? And then we talk about the operational efficacy of those programs. Do we have the right leading and lagging indicators set? Are we hitting those? Do we have the right accuracy in place in terms of our coding, right? Things of that nature. And ultimately, that's all going to fall under the umbrella of, oversight, as well as it being done compliantly, right? Are we going to, so are we setting ourselves up for our future selves in a few years that, hey, we did it the right way? Or are we operating in a gray area, right? And so those are some of the things to look at. Or maybe we're operating blindly. We don't necessarily understand all of the complexities and nuances and things to look for within our programs. And so what we don't know, that could come back to be, negative on the program down the road. And so ultimately with that, it comes down to, are we engaging sponsors, right? Whether those are internal sponsors or are those external sponsors. So an example would be of a external sponsor could be the providers that we're collaborating with for an incentive program. Or also when we talk about our internal sponsors, ultimately, where does that risk adjustment program roll up within the organization? And what are some of the dotted line sponsors that are dependencies within the risk adjustment program? Whether that's going to be claims, IT, could be member enrollment, things of that nature, that really have a big impact on the risk adjustment programs. So I know I alluded to the 6 components of a risk adjustment program, at least that we see in terms of kind of best practice. And these are, more or less buckets of programs, right? We have our prospective programs. So think member engagement, in-home assessment, in-office assessment, really trying to facilitate a face-to-face visit between the member and the provider that's going to be eligible for risk adjustment. And that can take a number of forms, right? That could be as simple as really reaching out to members and getting them to encouraging them to go see their PCP or their appropriate specialist. That could be in the form of working with a in-home assessment vendor to help to engage those members that don't necessarily have access to care. That could take the form of an in-office assessment program in which members are visiting their providers and having all those conditions or gaps in care being addressed there in the office setting. And so that really rounds out prospective programs. There's some other kind of either health fairs or mobile clinics that potentially fall under that umbrella as well. Let me talk about retrospective programs. We're always talking about ensuring that what has occurred in the past is accurately captured and submitted to CMS or the Edge server, right? So we think of retrospective as the data that we're supplying an accurate representation that can ultimately withstand a RADV audit from a clinical documentation and substantiation perspective, right? So always looking at it through that lens. And with all that, we have this broad data infrastructure that these programs are dependent upon, and also are the endpoint of data generated from these programs. So for example, when we talk about data submissions, that is going to be your endpoint for getting data that is the byproduct of prospective programs or retrospective chart review to the Edge server or to CMS via the EDPS process. When we talk about analytics and setting strategy and identifying the correct universe of members to engage for prospective programs, or the right universe of charts to chase for retrospective programs, or the right universe of encounters that need to be remediated for data submissions, that's all really a data-driven sort of exercise. And the systems that are in place, whether that's internal or through a vendor partner, those are really key and critical in ensuring that there's continuity across the entire spectrum of the program, right? Compliance really is across the board, right? So ensuring that the programs, whether prospective or retro, are done in a compliant manner, as well as ensuring that there is correct oversight from a compliance standpoint with the data activities as well, right? So compliance is really throughout the entirety of the risk adjustment program, ensuring that we have complete, accurate diagnosis codes, that contractual SLAs are being upheld, things of that nature. So we'll dive into the compliance nuances here in a minute. And then really when we talk about those last two bullets in terms of these pillars, we have provider and executive engagement, and this all comes down to communication, right? Are we communicating the right level of information to the right audience at the right point in time, right? And it's going to be a very different amount of information and a conversation between an internal stakeholder versus an external stakeholder, and even your internals understanding whether we're talking to the coding department or the care management department or pop health, things of that nature. So really, it's know thy audience is kind of the important takeaway for provider and executive engagement. So diving into setting strategy for our prospective programs in 2025, and really this starts off by looking at 2023 and 2024 past performance. And so we've called out a number of different elements to look at. First and foremost, it's a member engagement rate is going to be the strongest leading indicator for this subset, right? And so anytime that we are trying to influence, in this case, member behavior in terms of seeing their provider or being seen by a close vendor partner, there needs to be a visit that occurs that generates a claim, right? And so when we see that as a percentage, that's really critical and important, as well as ensuring that there are some of the follow-up activities such as care planning that are being done, as well as a direct outcome of those engagements. And so that's more of a leading indicator. A more of a lagging indicator is going to be HCC recapture rates. So if we look at a member by member or beneficiary by beneficiary level of the chronic conditions that are year over year, right, that persist, and looking to see of those, how many are being addressed as well as redocumented in the current year versus years prior, right? And so that provides us a recapture rate, which helps to look at the quality of that visit, the depth and the detail of that visit, as well as the documentation, right? And so looking at overall performance at the vendor level is going to be important as well. Again, you have the leading indicators such as completion rates, as well as then your more of a lagging indicator, which would be quality of documentation and coding accuracy, right? And so those are classically some of the main SLAs. Could be at the coding accuracy rate, or it could be turnaround times for emergent care or case management referrals, things of that nature that fall more under kind of your care planning sort of accuracy buckets. Same can be said in some regards to provider performance levels. So if we talk about an in-office assessment program in which members are being seen by the PCP in the office, and data is being exchanged so that the provider can really use the entire universe of information that's being supplied by the health plan when it comes to understanding what are all the gaps in care, or what are all the chronic conditions for that given patient, making sure that member is seen first and foremost, and that those conditions are documented within the medical record is really key. And then ultimately, right, do we have the right care management in our processes and referrals in place for those high-risk members, right? And so we'll see that as a common thread, especially with some of the feedback that industry is receiving from some of the OIG reports and whatnot, is that for the high-risk members, it's not enough just to document the condition, but there needs to be a follow-up in place for the care of that member to ensure that they are getting the appropriate care they need, as well as the support within the organization and on the provider side. So that's really key. So ultimately, right, it's looking through the lens of 23 and 24, that performance that's ultimately then going to help drive 2025 strategy. So when we think about strategy, the first and foremost, we need to look at the universe of members that will be engaged, whether that's member engagement, whether that's in-office assessment, in-home assessment, right? Understanding new members or those that are renewal members, right? And so there's going to be a different strategy in place, right? We know quite a bit about our existing membership. The new membership, we might get some information from either early prescription fills or potentially HCCs that the member might have via the MOR file / the HCC mod file if they're coming over from another managed care organization. But oftentimes, there isn't a whole lot to go off of in terms of new information. And so setting out that cadence and that structure as to, what would be considered an initial kind of universe identification versus subsequent targeting lists throughout the year is really important to set that kind of cadence throughout the year. Again, when we look at members that are going to be either allocated to an in-office, an in-home, or member engagement strategy, part of that is looking at historical behavior, right? Are they already going and seeing the provider on a regular basis, right? That might be one indicator versus a member who hasn't necessarily gone and seen their provider, except for maybe urgent care in the last year or two, right? And so that's going to help drive strategy as to what members do we push to, let's say, a trusted in-home assessment vendor versus those that would be more towards an in-office assessment program. So ultimately, understanding any sort of gaps within the capabilities can help to drive, what are those vendor strategies that are ultimately going to help, provide the capabilities to the program that, kind of fit all the different use cases that we've talked about. And then ultimately, right, do we have the correct training material up to date and it accounts for any sort of the compliance or other changes that are coming down the pipe. Shifting focus then on the retro side of the house, again, looking at prior year 2023 and 2024 performance, the biggest, it may be the metric that most focus on would be the year-over-year completions, right? And kind of looking at that volume. But kind of delving deeper into that, there are a number of different components. We have a chart retrieval rate, right? What percentage of the charts that we targeted did we actually get in the door, right? How many of those that we got in the door, we then got coded, right? Is there a gap between we had records in the door, but we didn't have enough bodies to code them all prior to the submission deadline, right? What is that coding accuracy rate at the coder level, the vendor level, the departmental level, and the organizational level, right? Are we hitting 95% or better accuracy when it comes to coding accuracy rates? It's just been, historically the gold standard. When we think about programmatic impact, looking at the number of diagnosis codes, whether adds or deletes, so we have to look at this both ways, right? And we're really focused on accuracy of diagnosis codes, right? How are we measuring the impact of the program in not only substantiating diagnosis codes that were left off of the claim, but also removing erroneous ones that are not substantiated by the claim or supported by the claim, right? And so understanding all of those elements is really going to help kind of paint the picture as to what's working well historically and what needs to be perhaps modified for 2025, right? And then this can also be applied then to any sort of vendor performance in which either retrieval or coding is vendored out, understanding based upon the contract terms and the SLAs in place, have all of those elements been, successfully achieved, or are there areas in which vendors need to be encouraged to improve, right? So all that to say is that that's going to help drive 2025 strategy and planning. And so part of that is looking back at not only the work done, but the outcomes that are achieved. It's then asking the question of, are we doing the right amount of work when it comes to the right level of charts that we're reviewing? And part of that is, looking at things like, are we doing enough to mitigate some of the high risk condition concerns that OIG has laid out, right? Are we including that universe within our targeted chart chase list? And do we need to allocate additional resources, whether that's internal or vendor resources, to ensure that we're covering the accuracy of our diagnosis codes across the board, right? And so when we think about that, it's working through, or kind of working backwards as to, all right, this is the amount of work that needs to be done, in this case, medical records to get in the door and coded. Are we staffed appropriately if we do internal coding or internal chart retrieval? Do we need to bring on additional bench strength? Or do we need to potentially leverage vendor partners in order to do the necessary amount of work to achieve the level of accuracy that our program has set out, right? And so when we talk about identifying that that universe for MA, no later than Q2 this year, is really kind of ideal to allow for enough time to, again, staff up if needed, but as well as truly get in and request and code those charts before 1/31/2026 sweeps. And then on the ACA side, we live under a much shorter and more truncated timeline. So really, it's looking at September, October for setting the initial chase list with additional chases being identified a little bit later in Q4. But given that short runway, it's important with Q3, Q4 really wrapping your arms around that chart chase universe. Now, I mentioned that data analytics and systems, especially IT systems, are really the bedrock and the backbone of risk adjustment. And so looking at any sort of model changes, right, whether those are diagnosis codes, CPT codes, or HCC mapping, when we talk about V24, V28, things of that nature, right? Are those conditions, are those changes being pulled through all elements of targeting logic, reporting, as well as any sort of prioritization, efforts? So an example, right, when we talk about encounter submissions, especially for new plans, right, making sure that, it's kind of like, new plan checklist, but getting enrolled with CFSC operations and being able to submit encounter data is really important. But then it's also having then full visibility across the entire life cycle of that claim when it comes, from EDI gateway on the front end, all the way through claims adjudication, transition of data to the reporting layers, and then ultimately looking at extraction of that data into your encounters engine, right? And ensuring that there's continuity of data and that nothing's being dropped, whether those are diagnosis codes, those are claims, those are CPT codes, that every step across the life cycle is really important. As well as, looking at things such as member enrollment, provider credentialing, things of that nature that could pop up down the road. And ultimately looking at, error reports and understanding, is there visibility for those reports that are they generated in a timely manner? Does that allow for accurate remediation of sort of issues that are going on? When we talk about analytics, we really talk about review of claims processing and other systematic or system changes. So, example would be any sort of influx of new membership or, new providers within the network, ensuring that if there's any sort of data sharing feeds, things of that nature, that those are all being accounted for. Those are really key from a data and analytics perspective, because ensuring that you really have full end-to-end visibility is going to drive in targeting as well as reporting and everything in between. So those are the main kind of strategy elements when we talk about analytics here in 2025. And ultimately, right, when we talk about anytime we are making any sort of significant change within the program, V24 to V28 shift or RxHCC V8 from V5, right, there are a lot of moving pieces, and ensuring that you have the correct modeling applied to the correct data service calendar year is really key to ensure that not only is the data timely, but it's accurate and it's actionable. Those are really key elements. Moving on to some of the compliance. When we talk about setting, kind of a plan for 2025, a lot of it just comes down to setting the appropriate schedule, right? And it's striking the balance of ensuring that your reviews are not inhibiting operations, but at the same time, they are providing enough timely feedback to make any sort of course corrections or changes throughout the year. So an example would be, chart chase or medical record review, chart coding. It's having real-time enough feedback in terms of coding accuracy and oversight to make any sort of changes and pivots either at the individual coder level or the vendor level to ensure that there's enough time to change behavior before the end of the year. Along that those same lines, we have the vendor oversight. Again, reviewing performance and ensuring that contractual SLAs are being met, as well as ensuring end-to-end continuity from those data exchanges is really key as well. When we talk about compliance on the provider side, it's taking any sort of those findings when it comes to diagnosis code accuracy and ensuring that education is going back to providers when there are instances in which a diagnosis code may not be supported by the documentation, and ensuring that, especially when we talk about the OIG high-risk diagnosis codes, right, when we look at those sorts of conditions, ensuring that there is, kind of full end-to-end continuity in that education back to the providers, and that it's done in a tactful way as well. So while speaking about providers, reviewing prospective and retrospective programs, if there are any sort of issues in terms of access to charts or data, that is something that oftentimes that strategy needs to be set on a provider by provider basis. And then ultimately, when we talk about engaging providers within the health plan, oftentimes the left hand and the right hand don't know what they're doing. When we talk about quality, risk, pop health, these initiatives are oftentimes happening simultaneously. And if those groups are siloed within the organization, it can come off as a fragmented sort of communication with the provider, right? So looking at more of a cohesive sort of approach oftentimes can reduce some of that abrasion with the providers. And ultimately, as we start to continue moving towards more and more value-based care opportunities, ensuring that risk adjustment is really in the fabric of those VBC arrangements is really important. All right, this is the last piece for me, but really like looking at executive engagement. So looking both upstream and downstream of your team, understanding again who owns risk adjustment for the organization, as well as who are the groups that have a direct impact with regards to the data that risk adjustment ultimately submits. So oftentimes, the canary in the coal mine is risk adjustment when it comes to rejected encounters, right? And that could be, from upstream provider or enrollment data, things of that nature that are really truly manifesting themselves through errors. And so ensuring that there are direct lines of communication and regular communication with those groups is really key to managing those data errors effectively and in a timely manner. All right, Alan, turning over to you.
Thanks, John. First, Garrett, I think you were going to deal with the first polling question, right?
That's right. So if you are playing along at home, I'm about to pull up a poll for you here, and this is the transition for medical HCC from V24 to V28 continues. What percent of plan payment will be applied for V28 for plan year 2025? 33%, 50, 67%, 100%, or CMS will postpone it, so I shall ignore it. We're going to wait for a few more seconds here for the results to come in. And we're going to show the results here. This is all anonymous, so feel free to answer, and we're going to show where you stack among your colleagues. And looks like we're still waiting. I'll give it about 5 more long seconds. While we're doing that, John, I may have you mute yourself if you're. Oh, actually, I'll mute you because we're getting a little bit of feedback here. So, gotcha. All right, so I'm going to go ahead and share the results here. And it looks like, Alan, are you able to see those on your end?
I'm sorry?
Are you able to see the results here?
I can.
All right, I'll just read them out so that I don't know that John is able to see with his limited view. But it is, we have 10% said 33%, 7% of you said 50%, 34% of you said 67% will be applied, and then 45% of you said 100%, and then there was 3% of you that said CMS will postpone it.
All right, let's go back to the slides then. Good afternoon, everybody. John, you want to go ahead and advance that? As much as we wanted the CMS to postpone this answer to be correct, the answer was 33% will be in, or 67 will be for version 28 this year, and version 24 will be 33%. So this is the second to the last year of that transition over from between the two HCC mapping models. So when we look at key changes for plan year 2025, a lot of these are actuarial based and finance based. There's a little bit of operational impact, but it's going to be largely for the people who are tracking the math on payment and such. We'll talk through those really quick or over the next few slides. So, as I said, the transition from 24 to 28 is one of the programs that is continuing. This year will be at 33% mapping to the version 24 model of the HCC, and then version 28 will be 67%. And then next year, that transition will be complete. For payment year 2026, data service year 2025. Then a couple of other changes that we'll note. One is the Part D changes, benefit changes, and I'll talk that through on the next slide. And then some of the risk adjustment changes from a pharmacy perspective. One other change that I did not include on this slide was that we are seeing the from a risk adjustment perspective, as most of you probably know, there's a demographic component and a diagnosis or condition-based component. And we are seeing in the factors for this year that CMS is waiting for low-income beneficiaries in particular. They're weighting the factors more towards the conditions than they are for the demographic. So one area to take a look at is those beneficiaries that are indicated as low income, making sure that you are tracking their conditions with the same level of vigor and focus, if you will, as those who do not fall into that category. John, you want to talk about the next, or go to the next slide? Thanks. So this is probably for risk adjustment folks, largely for information, but it is kind of important information to know when you're considering the overall impact on your program. Over the plan years 24 and 25, the amount of money that the plan is responsible for Part D payments has been shifting away from CMS and back to the health plans and the drug manufacturers to a certain extent. So, as you see on the for 2023, the first component was the deductible, and the beneficiary is fully responsible for that. Then there was an initial coverage level that the beneficiary had to pay 25%, and then the health plan would pay 75%. And then it went into the coverage gap, 25%, 5% for the health plan, and 70% for the manufacturers. And then at the catastrophic level, it was 5% for the beneficiary, 15% for the plan, and then CMS picked up the tab for 80%. This year, the change we saw was that the 5% for the beneficiary at the catastrophic level was taken, that had to be borne by the health plan themselves. And then coming on for 2025, there's a more significant shift, and that is, again, the deductible level is 100% borne by the beneficiary. The initial coverage level is still 25% for the beneficiary, and then split 65 and 10 between the drug manufacturer and the health plan. And then at the catastrophic level, the health plan is covering 60% of that expense, the manufacturer 20, and CMS down to 20 as well. The reason we bring it up here is just for your awareness. All the other significant changes, the member max has dropped down to $2,000. So the health plans are going to be picking up a more significant amount of the tab of the risk for Part D coverage. This operationally really does not impact the risk adjustment program, but it does make sense to be aware of it, particularly for people that are falling into that high risk catastrophic coverage area, making sure that we're identifying those individuals and understanding, are we getting them fully risk scored? Are we getting all of their conditions captured? Because the plan is at risk for those monies. Next slide. So I just put this slide in here really to show some of the mapping differences. There's kind of a combination of factors here. One is the change from the model 24 to 28. The other is the fact that CMS is kind of splitting the mapping. It used to be all the mapping went through the the mapping was combined, and CMS is kind of splitting the mapping between HCC and RxHCC. So it's important to understand conditions that um, may not be mapped between the two that you need to make sure you're following up and capturing. So um, when we look at the diagnosis codes that map to HCCs, there's about 5,300 of those. But when you look at those that map to version 28, but do not map to 24, that's 46 conditions, and that's the small table down below. So there's really five HCC, RxHCC codes that are affected that if you have people with those diagnosis codes under version 24, they're not going to get mapped under version 28. So identifying who those folks are so that you can make sure, again, that you're properly documenting their conditions would make sense. The other thing to be aware of is that the larger table shows the 533 conditions that currently map to version 24 but do not map to version 28. So understanding those conditions, those diagnosis codes for those RxHCCs, so that you can make sure that if there is an appropriate equivalent, that you're capturing those, but there's going to be some diagnosis codes drop off from the mapping for the RxHCC that used to be available in version 24, but is going away under version 28. Next slide, John. So as far as recommendations, the 2025 changes really aren't have an overall impact or overarching impact to the risk adjustment program operationally. The main changes are understanding the variance between version 28, 24, and 28, making sure you understand that this year because it is heavily or more heavily weighted to version 28, and then next year it'll be fully weighted towards version 28. But a couple of other recommendations associated with this. When you look at the diagnosis gaps from the slide above, making sure that you're identifying the beneficiaries that fall into those categories where you're losing a diagnosis code from version 24 to 28, making sure that you've got those individuals identified so that again, you can find out if there is an appropriate equivalent so you can get them properly risk adjusted. The other thing in the top 10-ish range kind of varies market to market, but verifying that the people that are currently in your risk adjustment program under an HCC, that you understand what their top 10-ish RxHCC conditions are so you can make sure, again, that you're capturing those individuals, getting them properly accounted for. As I mentioned earlier, the weighting for lower income beneficiaries is moving more towards their conditions. So making sure you identify low income beneficiaries and are giving them the equal level of attention, if you will, from a risk adjustment perspective. And then using your Rx data to identify the beneficiaries for prospective and retrospective programs. The pharmacy data, with some of the clients that we work with, we don't see a whole lot of use of the pharmacy data to identify. You can't use necessarily a diagnosis code for risk adjustment purposes directly, but you can use that for sleuthing out proper diagnosis codes that a beneficiary should be seen for or evaluated for. All right, next. Garrett.
All right, we got another polling question for you. So this should be up on your screen here. You will see it says, what DX code categories were recently added to OIG high-risk DX code audit reports the second half of 2024? Again, these little quiz here is anonymous, but so go ahead and fill it in. COPD, diabetes, pressure ulcers, sepsis, or end-stage renal disease. So we're going to give this a few more seconds to come through. And then I will read out the results here. And I apologize if you're hearing a little bit of an echo. Okay. We'll give it about 10 more seconds. And again, which of these categories were recently added to OIG high-risk code audit reports in the second half of 2024? Okay, it looks like most of the results have come in now, so I'm going to shut it down in another 5 long seconds. 4, 3, 2, and 1. All right. And John, I'll read these out so that you can see, hear the results too. 13% of you said COPD, 9% said diabetes, 43% said pressure ulcers, 26% said sepsis, and 30% said end-stage renal disease.
All right, thanks, Garrett. All right, so we threw a little bit of a trick question at you. The answer was actually sepsis and pressure ulcers. The OIG has published 6 reports this year in 2024. 3 of them were published in September. And in September, they did add sepsis and pressure ulcers as high-risk conditions. The sepsis on the 2 reports, it was substantiated at a 56.7% rate, and then the pressure ulcers showed up on 1 report at 69%. Specifically, what the OIG was looking for these reports was, in the case of sepsis, that there was a single diagnosis code in a physician or outpatient setting with no follow-up inpatient visit. And their statement there is that if somebody is diagnosed with sepsis in a physician or outpatient setting, there should be an inpatient stay as treatment for that. And then on pressure ulcers, they're looking for a single instance of a pressure ulcer related diagnosis code with no other treatment plus or minus 1 year. And see, the OIG is going back several years, so they're able to take a look at that plus or minus 1 year. And their contention on pressure ulcers is if the diagnosis is appropriate, there would typically be more than one claim for treatment for pressure ulcers. So those are the 2 conditions that they've added in the most recent reports. The other thing that the OIG has indicated is a much higher scrutiny on in-home assessments, and specifically they're looking there for diagnosis codes for in-home assessments or unlinked chart reviews that are associated with in-home assessments. Basically, if the diagnosis code is solely coming from an in-home assessment, they're considering that suspect or at risk of being inappropriate. So there's a link to their report there, but a single instance diagnosis code from in-home is going to be fall under further scrutiny. Is that the last slide, John?
All right. Looks like we have a little bit of time for some audience questions here. And John, I'm going to see if I can unmute you here. All right. So if you have a question for either John or Alan, go ahead and drop that now in your control module, there is a place which is different than the chat. We had some questions coming through the chat, but I'm going to go ahead and ask some of these in no particular order, and we're going to get to as many as we can. Starting with this one, for smaller health plans with limited staff and resources, what would be the top 2 or 3 objectives to start with?
John, you want to go with that?
Yeah, I'll take that one. Part of this is thinking about just being realistic in terms of where we are with the year. So I always think, first and foremost, optimize the current existing programs you have in place. And so a lot of times the most important thing is from a data submission standpoint. That's really your foundation, right? So ensuring that all known data is getting submitted to CMS or the Edge server is first and foremost a really critical first step. And then on top of that, it would be any sort of existing program you have in place, whether that's prospective or retro. It's really taking that to what I would consider to be truly a top performing program based upon those metrics that we laid out, right? And then from there, since we said 2 or 3 objectives, it's starting to look at those capabilities that are kind of that next level, right? So let's say that the health plan has strong submissions, strong retro. It would be building out a robust prospective program, right? And part of that would just be being realistic as to is the first step going to be a member engagement program in which we can do that internally, right? We have call center staff that can make outbound calls, or can we have a means of sending letters to members? I know that's not always ideal, but things of that nature versus something that would be a either multi-month or multi-quarter implementation process. You might not necessarily reap those benefits until truly 2026 dates of service. So just being really realistic as to what are the actions that I can take right now that will have an outsized impact on risk score accuracy for 2025 dates of service.
You're on mute, Garrett.
You're muted.
I did this earlier today too. Okay, next question here is on the OIG audits, what are the risks and how far back should the health plans look?
What are the risks? So the risk of being audited is different from the risk of, say, being randomly selected by CMS for a RADV audit. The RADV audit, CMS is going to target their resources towards larger plans because that's where they're possibly going to find more bang for the buck. On the OIG, every health plan is providing the evidence on a monthly or quarterly basis to CMS, and the OIG is monitoring that. And so they're able to run their analytics and determine what health plans are meeting have conditions that are meeting the criteria and which aren't. And we have seen health plans as small as 9,000 beneficiaries up to 900,000 beneficiaries. So every health plan is subject to that. We have seen reports in September. The reports went back to, I believe it was 2015 plan year was the earliest. So the reports that we've seen to date, I think there's been 37 published. They've been in the 2015 to 2018 time frame. I don't think we've seen anything newer than that. So yeah, that's pretty much the window of time so far. But the OIG is going to start moving closer in the date with the new year, I'd expect. You're back on mute, Garrett.
Of course. Next question here is, I am a provider. What does this all have to do with me?
That's a great question. Alan, do you want me to take a pass and you can kind of backfill from there? I would say first and foremost, especially any providers that are in any kind of value-based arrangement or total cost of care, right? Understanding the mechanisms of what the health plans are encountering when it comes to accurate revenue is going to be really key, especially if either it's a full or partial capitation is being taken on by the provider group. Ensuring that appropriate revenue for that panel, that membership is really critical. And so, understanding then from there the actions and the activities done by the provider in the clinic or via data exchange is paramount to ensuring then that the reimbursement from that value-based care arrangement is appropriate. So I would say that that's maybe the first place to look, and then ultimately understanding then from a broader context, collaborating with the health plan with these high-risk members is ultimately going to help then the health plan provide the right resources and programs to the patient where there's additional, I'll call it complex care that's required. And so there health plans, depending on the size of the health plan, right, they have additional resources, whether that's going to be in some sort of member education program when it comes to it could be specific diabetes or COPD, or it could be any other sort of disease state. There are resources that are often available, case management as an example. So making sure that there's full transparency in terms of the data going back and forth can go a long ways to getting those patients the right resources that they need. Alan, anything else you want to add on that?
Yeah, just if you call it battlefield intelligence, if you will, knowing how the person who's paying you money is getting paid doesn't hurt. And the health plans are under pressure to have effective risk adjustment programs. Plans are going to put pressure on providers to effectively participate in that. And so as a provider to understand those parameters. And the other thing that's a lot of times not emphasized with risk adjustment is, risk adjustment is typically around collecting diagnosis codes. But risk adjustment is also about making sure care plans are in place to address those conditions. And so as a provider, understanding how they can participate with health plans to ensure that those conditions are getting properly treated, and the risk adjustment program can kind of be leveraged in that process.
All right. Well, unfortunately, we are out of time for today. We do have a couple other questions, so I know that there was a few of you that submitted questions. But don't worry, someone will reach out and to answer your questions via email. But I wanted to real quick thank you, John. Thank you, Alan, for a fantastic presentation. I know there's a lot here. There's a lot of material that was covered, and so what's going to happen is you're going to receive an email when we're done here. I can give it about an hour or so, and it'll have a link to the recording as well as to the slides, so you can download them and see them and review those at your own leisure. As we close out here, wanted to encourage you all to head over to vbcexhibit.com. And there you will find the ATTAC Consulting virtual exhibit booth, which is kind of cool. And there's a lot of different resources there that you can read up on them, see what they're doing in the space, really educate yourself on them. If you would like to get in touch, obviously there's ways to reach out through there. And I'm happy also to facilitate an introduction if that's easier. But there's a lot of great resources there. Also in the library at vbcexhibithall.com is where this webinar will be archived, as well as there's a number of other webinars by ATTAC and others that I think will be really meaningful for you. And then as a final note, if you would like to reach out to either John or Alan, feel free to do so. Their contact information is here on this final slide. And again, if you would like me to facilitate an introduction for you, I'm happy to do so, and you can reach out to me directly. Wanted to thank you all for spending your afternoon with us. Thank you so much, and Alan and John, for your time, and hope you all have a wonderful rest of your week and happy holidays as we are rolling up in December here. Thank you guys so much. Join
Thank
us
you.
next time. Bye-bye.